Next case is a 65-year-old man who comes in because he needs a little roto-rooter of his prostate. And he's got an elevated PTT and a normal PT. And the urologist says, "Hey, what's that? I got an elevated PTT and a normal PT. What's that?" Could this be hemophilia? Elevated PTT and a normal PT? Could it be? Very could be, except for one little problem. He's never bled in his whole life. He's had no petechiae. He's got no history of bleeding. He even got cut and he had no bleeding. He got shot in the chest and he had no bleeding. He's never had any bleeding of any kind. So this can't be hemophilia with a guy that's never been bleeding. It can't be. You can't have it. Well, an elevated PTT and a normal PT, it can't be hemophilia. It can't be hemophilia A or hemophilia B, where you'd have an elevated PTT and a normal PT. And he says to you, "I've never been bleeding." As a matter of fact, he says he's got a history of DVT times 2, pulmonary emboli times 3, and he's gravida 24, para 0, 0, 24, and 0. SLUT. And he tells you that his VDRL is positive and his FTA is negative. And he's got an elevated PTT and a normal PT and no history of bleeding, but he's, hypercoagulable, which is to say thrombophilia. Thrombophilia. I love to thrombose. The proper term for hypercoagulable states is thrombophilia. I love to thrombose, okay? So, elevated PTT. You say, "How long have you had this elevated PTT?" And he says, "I have no idea." "Well, why don't you have any idea? Your PTT is very elevated." And he goes, "Well, I have no idea because I've never bled." And he says, "Well, how long don't you know this is a very elevated PTT, you never had any history of bleeding? Why not? How long? He goes, "I don't know." "Do you know how high your PTT is, Doc? Do you know what your PTT is?" And you go, "No, actually I don't. I don't know what my PTT is. I don't because I've never bled. So why should I have it measured if I've never been bleeding?" So there. So I've got an elevated PTT and a normal PT and no history of bleeding, but I've had 24 spontaneous abortions. A false positive VDRL and thrombophilia, and that is clearly and only the lupus anticoagulant. It is clearly and only the lupus anticoagulant. An elevated PTT and a normal PT and no history of bleeding. An elevated PTT and a normal PT and no history of bleeding is clearly only the lupus anticoagulant. The lupus anticoagulant, an elevated PTT and a normal PT and no history of bleeding. Lupus anticoagulant. Can't be any other thing. Now, if they tell you that a person has all of this hypercoagulableness, and they tell you that it's a protein C and a protein S deficiency, or an antithrombin 3 deficiency, or that you have a lupus anticoagulant, what of those is going to be the most common one? Which will be the most common? Not antithrombin 3. Protein C, protein S, antithrombin 3, lupus anticoagulant, or a factor 5 Leiden abnormality. Factor 5 Leiden will be the most common one. So the most common cause of a hypercoagulable state is the factor 5 Leiden mutation. The most common cause of a hypercoagulable, better known as thrombophilia, I love to thrombose state, is a factor 5 Leiden abnormality. However, looking at the labs on this patient, even if they tell you that he has 27 DVTs and 34 pulmonary emboli, why does this one have to be the lupus anticoagulant? because it's the pi PTT. The only one that gives an abnormality on the PT-PTT. Out of all of these, protein C, protein S, antithrombin 3, lupus anticoagulant, factor V latent, the only one of these that gives an abnormality in the PT-PTT is the lupus anticoagulant. That's the only one. The only one that gives an abnormality in the PT-PTT is the lupus anticoagulant, none of the others. Clear? Now, this person will be confused with a bleeding disorder. This person has an elevated PTT and a normal PT and no history of bleeding. And it seems difficult now. But once you have the person, once you have seen it before, once you have seen an elevated PTT and a normal PT and no history of bleeding or hypercoagulable state, it will always jump to your mind in the future. It's only difficult when you've not seen it before. When you've seen it before, then you go, oh, elevated PTT, normal PT, no history of bleeding, lupus anticoagulant, anticardiolipin antibodies. What else could it be? What else could it possibly be? What else could it possibly be? Okay. Treatment for this guy. What would the treatment be for him? With that elevated PTT, what do you give him? Nothing. Nothing. He's got no symptoms. This guy, in this case, had no symptoms from that lupus anticoagulant. He had no symptoms, so you don't have to give him anything because he has no symptoms. You'd only have to give them something. You'd only have to give the patient something if they had symptoms. So only if they had symptoms do you actually have to do anything about it. Only if they have symptoms. So this guy doesn't need anything. He just needs a diagnosis. That's all. Next case. Yes. If this were a pregnant woman, you would treat with aspirin and maybe steroids. If this was a pregnant woman. But that's not what that case was. This is different. That guy in that case had no hypercoagulable state. That guy in that case was not thrombosing. So the answer is no therapy. The point is not to give him FFP prior to surgery. The point of that case is two things. Step 3 is happy if you can recognize one, just recognize it's a lupus anticoagulant. You'll do just fine. The other thing about step 3 is, if you can recognize that case of the elevated PTT and normal PT and know it's a lupus anticoagulant and don't give FFP, don't give cryoprecipitate, you'll be fine. If you can get away with not giving clotting factors to the person with the hypercoagulable state, that's all that's required for you. Oh, you mean if they have coagulation, what would you do? Give anticoagulants. If they coagulate, you give anticoagulants, like Coumadin. Next case. Now, the cases, some of them are somewhat redundant. Okay? So there's 3 or 4 DICs. There is an infectious disease, 2 or 3 pneumonias, 2 or 3 meningitises. See, when these cases were originally developed, they were originally developed for a long 6-week Step 3 course. But nobody is able to take the amount of time that it takes for 6 weeks of Step 3, because usually people are coming in on a week's vacation off of their residencies. So consequently, the materials that you have in the notes and the number of cases, the materials you have in the notes and number of cases is the materials and the notes that you'd get off of the 6-week course. So therefore, some of the cases we don't cover in class because you can't take 6 weeks of stuff and stuff it into 10 days. So we do most of it, but we give you the extra materials. So I don't want to hear any of your pathetic whining about, how come we're not doing every single one? Because you can't get 6 weeks into a 10-day course. You notice my restraint on that, don't you? So, here we go. 28-year-old woman had fever receiving Hodgkin's disease, okay, fatigue, and a hemoglobin of 7, and During the first transfusion, during the transfusion, she becomes ill. So when it says during the transfusion becomes ill, it can only be one thing. Huh? Can only be one thing. Come on. It's a matter of scrotal fortitude. Come on. Mismatch, but which type of mismatch? I mean, mismatch can be a lot of things. I don't date Hindus. You could say which one. I do, but the thing is, you could say which one it could be. Come on. Which one? Mismatched in which way? My mother doesn't like you. No, which way? Huh? ABO mismatch. ABO mismatch as to, don't bring home a Protestant. You know what I mean? So the thing is, ABO mismatch. Don't bring home anyone who's A negative. That's more appropriate. Okay? So the thing is, ABO mismatch, when you have somebody developing the symptoms during the transfusion. Right away during the transfusion, it's got to be an ABO incompatibility. This history, this physical, this history, this physical. The hemoglobin is going into the urine, and that's why it's reddish-brown. She's oozing from all over the place. This history, this physical. The best initial step is stop the transfusion. That's true. Except he would say stop the transfusion, except it says the transfusion has been halted. So it's already been done. So what's the best initial step now? Benadryl. Good. Should get Benadryl? What do you say? Come on, keep scratching. Get it across that corpus cavernosum. What? Fluids? Refluids, Benadryl, or recheck the transfusion sample. Which one? First. Initial step. Fluids is first. Fluids is first because the person is hypotensive. Fluids is first because the person is hypotensive. Fluids is first because the person is hypotensive. So, which flavor of fluids? Normal saline or ringers are both fine. Surgeons like ringers, internists like saline, but it doesn't matter. Both of them are fine. Just not half normal saline, not D5W, not quarter normal saline. The point is either one. Either normal saline or ringers is fine. And the person is having hypotension, tachycardia, fever, and it's fluids first. And we have low platelets, high PT, high PTT. And we go, high PT, high PTT. High PT, high PTT can only be three things. There's only three things that give a high PT and a high PTT. Liver disease, vitamin K, and DIC. I look at this person, I see that they have a low platelet count, and automatically I know that it has to be DIC. Normally, prothrombin activates fibrinogen. Normally, prothrombin activates fibrinogen by splitting off a piece of fibrinogen. Normally, prothrombin activates fibrinogen by splitting off a piece of fibrinogen to activate that fibrinogen and turn that fibrinogen into fibrin. To turn that fibrinogen into fibrin, the prothrombin splits off a piece of that fibrinogen to turn that fibrinogen into fibrin. What is that piece of fibrinogen called that's split off to activate the fibrinogen into fibrin? Fibrin split products. That's the thing about fibrin split products. They're the piece of fibrinogen that is split off to activate it into fibrin. Now, in DIC, everything is being consumed. PT is up, PTT is up, the fibrinogen is being consumed, and the fibrinogen level goes down, and it's converted into fibrin. Fibrin, in its turn, fibrin gets chopped up. Fibrin gets chopped up by plasmin. Plasmin will chop up fibrin and convert that fibrin into D-dimers. So that is why the diagnosis of DIC is based on seeing elevation of everything. Elevation of PT, PTT, the fibrin split products, because it's consumed fibrinogen. The fibrinogen will get all consumed up and turned into fibrin. So the fibrinogen level goes down, the fibrin split products goes up, because fibrinogen gets converted into split products and D-dimers. Now, what is it that converts plasminogen? There's something that converts plasminogen to plasmin. What is it in the tissue that activates the plasminogen? Tissue plasminogen activator? Yes. That's the thing in the tissue. That's the thing in the tissue that activates the plasminogen to plasma is tissue plasminogen activator. But this only happens before the fibrin can get cross-linked up. Only before that fibrin can get cross-linked up and preserved and stabilized by factor 13. You see, this is why after myocardial infarction, how long is TPA good for after myocardial infarction? Up to how many hours is it indicated? 12 hours. 12 hours after an MI. 12 hours after an MI. How long after a stroke? 3 hours after a stroke, 12 hours after an MI. TPA. Because TPA will only work on getting that fibrinogen chopped up, that fibrin chopped up, before factor 13 comes in and cross-links up and preserves the fibrin. How long does it take for the factor 13 to come in and cross-link up and preserve that fibrin? How long does that take? It takes about 3 to 12 hours. Okay? TPA is good for 3 hours after a stroke, for 12 hours after an MI, because TPA is only good for as long as before it takes the fibrinogen and the fibrin to be cross-linked up by factor 13. Once factor 13 cross-links up and preserves that fibrin, once it's preserved up, the plasmin can't chop it up into D-dimers. Now, that's why the PT and the PTT are up. The fibrinogen is down because the fibrinogen has all been converted into split products. The urine is positive for hemoglobin because the red cells that get destroyed in the intravascular space release free hemoglobin, which goes out into the urine. Why is the BUN and creatinine up? Why is the BUN and creatinine up? Huh? Dehydrated? Maybe. Renal. Oh, there's creatinine problem because there's renal. Why? That's saying that's like saying there's low oxygen because there's hypoxia. Hypovolemia can give an increased BUN to creatinine ratio. Hypovolemia can give you an increased BUN and creatinine ratio, but hypovolemia doesn't give you an increased creatinine necessarily. It's because hemoglobin is directly toxic to the kidney tubule. The kidney tubule does not like being bathed in hemoglobin. That kidney tubule does not like being bathed in hemoglobin. And that's the problem. Okay? That BUN and creatinine are both up because they are being bathed, the kidney tubule is being bathed in hemoglobin. And they're killing the kidney tubule. Okay? The treatment for this patient. This is DIC, elevated PT, elevated PTT, low platelets, and the person is bleeding from all over the place. What's the best initial therapy for DIC? In this case, I can't hear you. Transfuse plasma or give heparin for DIC? So give heparin. Give heparin. Heparin. Take your drink water. Would you like that with your main course or with your appetizer? fresh frozen plasma. Heparin would be the most common wrong answer. It would be very wrong to give heparin to someone who's bleeding to death from his DIC. This person's bleeding to death from their DIC. They're oozing from all over the place. And since they're oozing from all over the place, the answer is to give fresh frozen plasma. Fresh frozen plasma and not... Now, would you give this person platelets? Why not? Why not give platelets? No, there is something wrong. The platelet count of 90,000 is not a normal platelet count. It's not that low. The answer is never answer to transfuse platelets when the platelet count's above 50,000. You can do cardiothoracic surgery with a platelet count of 50,000. So never give platelets when the platelet count is above 50,000. It's not necessary when the platelet count is above 50,000. It's not necessary. So no platelets when the person's platelet count is this high. Any cause of big tissue destruction, hemolysis, tumor lysis, rhabdomyolysis, activates the clotting cascade. Anything that activates that clotting cascade can cause DIC. Elevated PT and PTT, low platelets. All the fibrinogen gets converted into split products and D-dimers. Don't answer heparin when the person is bleeding. Fresh frozen plasma. If the platelet count was 20 or 30,000, you might give platelets, but not in this person. If you look at the rest of the blood tests, the haptoglobin being low, the bilirubin being high, and the LDH being high is just hemolysis like any other form of hemolysis gives these labs. Any form of hemolysis can give these labs. It's not specific for DIC. Now, this next case is just another blood transfusion reaction, okay? So we're not going to cover this one specifically since it's just another blood transfusion reaction. It's a minor blood group transfusion reaction. Let's go on to the next one. "38-year-old man, emergency department. A week prior, and you look at this guy, and you go, oh, look, he's got a stiff neck and a headache and a fever. I know what he's got. I bet he's got meningitis. And then they tell you, you know what? He's got meningitis. I know what I should do. I should do a lumbar puncture. And they tell you, you know what? He's had a lumbar puncture. And then you know what? It says, oh, gram-negative diplococci. Gram-negative diplococci, I should start some ceftriaxone for those gram-negative diplococci. That's the next step. And then they tell you the ceftriaxone's been started. The problem with this case is that everything has been done already. Everything has already been worked out. Everything has already been done. So in this case, it's meningitis, this history, and this physical. What's the best initial therapy or step or action in this patient? His fluids again. His fluids again, except he's on dopamine. But it's still the same thing. It's still fluids for a hypotensive septic guy. It's still fluids for a hypotensive septic guy. So, once again, it's a guy who's got low platelets, high PT, high PTT, low platelets. So it's DIC again. But this time, instead of it being from hemolysis, tumor lysis, rhabdomyolysis, it's just DIC from sepsis. Would you transfuse this guy platelets? No. Why not? Because it's above 50,000. Because the platelet count is above 50,000. Because the platelet count is above 50,000. Okay. Next case. "75-year-old man comes in for a routine office visit. has a history of mild hypertension. I've got an elevated total protein, and I've got a monoclonal spike on that total protein. You could not possibly get the diagnosis off of this history and physical. You couldn't possibly get the diagnosis. You couldn't make the diagnosis off a guy who just comes in for a routine office visit and has a high total protein. You couldn't possibly get this. You couldn't get the diagnosis off of this until you had some of the other lab tests. So it was only when you did the electrophoresis and you saw some of the other lab tests here, only when you do the other tests and you get some of the lab tests, then you can tell what is going on. Because only then you get that monoclonal spike that's high, that's there. Now this is like talking about myeloma. In myeloma you have this plasma cell. The plasma cell makes a bunch of things. And that plasma cell can make IgGs and IgAs that's visible on the serum protein electrophoresis as a monoclonal spike. What else does that plasma cell make in myeloma? In myeloma, what else does the plasma cell make? Here you have the monoclonal spike. You have the monoclonal spike for like a person in myeloma. What else does the plasma cell make in myeloma? Capillary lambda, light chains, also known as, you get a BJ in the urine. Okay, got a little bench-Jones protein. Okay, little bench-Jones. What else is that plasma cell making? Hyperuricemia. Hyperuricemia because the cells get destroyed and make hyperuricemia. Now, when we talked about hemolysis before, why didn't the hemolysis make the hyperuricemia as well? Huh? Because these cells have DNA. These cells have nucleic acid. And since these cells have nucleic acids, when the nucleic acids are found in the nuclei, so we call them nucleic acids? That's a good thing to call things that are in the nuclei, nucleic acids. Because it has nuclei, you have hyperuricemia. But that's not the main thing that the myeloma plasma cell makes. What's the most common presentation of myeloma? What's the most common chief complaint of myeloma? Infection, no. Bone pain. Bone pain because you have fractures. Bone pain because you have fractures. Bone pain because you have fractures because the plasma cell is making osteoclast activating factor, which is affecting the bones, which is causing a hypercalcemia. And the most common presentation is bone pain, the monoclonal spike, and a greater than 10% plasma cells. And that's myeloma. Myeloma is a monoclonal spike and bench-Jones protein and hyperuricemia and bone lesions. This guy has a monoclonal spike, but you know he's not anemic. This guy has a monoclonal spike, but, you know, he's got no bone x-rays. This guy, he's got no abnormalities on bone x-ray. This guy has a monoclonal spike, but he's got no hypercalcemia. This guy has a monoclonal spike, but he doesn't have bench-Jones proteins or hyperuricemia. This guy has a monoclonal spike, but he doesn't have 10% plasma cells. This guy has a monoclonal spike, but he doesn't have any of the things that go for myeloma. I see a high total protein. I get electrophoresis. The electrophoresis shows a monoclonal spike. Waldenstrom's would be an IgM. Waldenstrom's would be an IgM. and which this guy does not have. So you have, what is the significance of MGUS? Oh, it's uncertain significance? So when you have a monoclonal spike, let's try this again. When you have a monoclonal gammopathy of undetermined significance, what's that called? I wish you could see the faces. They look like someone having a bowel movement. When you have a monoclonal gammopathy of undetermined significance, it's called?
Idiopathic.
A monoclonal gammopathy of undetermined significance. A monoclonal gammopathy of undetermined significance means that you have a monoclonal spike, but you don't have the bone lesions. You don't have the hypercalcemia. You don't have the other things that go along with myeloma. You have a small number of plasma cells. You have a lot of things, but you don't have the things that go for myeloma. Therefore, there's no treatment. There's no treatment. So when you see this, the question is, rule out myeloma, no therapy. Rule out myeloma, and then there's no therapy. Now, the blood is made up. Well, we have red blood cells, white blood cells, platelets. Yeah, you with me so far? I'm sure you are. Well, the white blood cells are made up of eosinophils and neutrophils and monocytes and lymphocytes. And the lymphocytes are made up of T cells and B cells. And the T cells are made up of somewhere around 1 to 185 different types of T cells. Now, one day, one of these T cells wakes up. He happens to be the T killer cell. One of these days, one of these T cells wakes up, the T killer cell. One of these days, the T killer cell wakes up, looks at the rest of the marrow. One morning, wakes up one fine morning, looking at the rest of the marrow, and all of a sudden has a very terrible experience. Goes, who are all you guys? And the T killer cell looks at the rest of the bone marrow and says, I don't recognize you. Whose B cells are you? Whose neutrophils are you? Where did you come from? I don't recognize you. You're foreign antigens. How did you get into my bone marrow? One day the T killer cell wakes up and can't recognize the people in his own community. Becomes convinced that they're foreign, and what's worse, becomes convinced that they're trying to kill him. And the T killer cell says, oh my God, what should I do? What should I do? Well, I am a T killer cell, so what should I do? Help? No. Suppress? No. No? No. I should kill. Yeah. One day the T killer cell wakes up, can't recognize the rest of the bone marrow, goes on a psychotic killing spree, and wipes out the rest of the marrow because it has a delusional disorder. Now, for the person, that's called aplastic anemia. But what this is a psychiatric disorder for the immune system. So if this is a psychiatric disorder for the immune system, what's the diagnosis for the T cell? No, it's paranoid schizophrenia with homicidal ideation. That's what this is. This is paranoid schizophrenia with homicidal ideation for the immune system. Now, if that's paranoid schizophrenia with homicidal ideation for the immune system, let's look at this patient. 25-year-old woman comes in because of fatigue. That's anemia. Colds and infections. That's neutropenia. Bruises on her arms. That's thrombocytopenia. Her chief complaint is, hi, I'm pancytopenic. Then she says, you know what? I am pancytopenic. And then it says down here, hi, I'm pancytopenic. and you get the feeling that she's pancytopenic. You do the initial blood test, and the most interesting thing is, well, golly, she's pancytopenic. She's got a low white count, a low red count, and a low platelet count. And not only that, she's got an empty bone marrow. Aplastic anemia means that you have pancytopenia of unclear etiology. You stop all the drugs and it doesn't get better. You stop everything and it doesn't get better. You don't know why it's happened. All you know is that you've got pancytopenia of unclear etiology and the bone marrow is empty. And it's because you're having a psychiatric disorder for your T cells. Now, if this is a psychiatric disorder for your T cells, with paranoid schizophrenia, with homicidal ideation for your T cells, what is Haldol for the immune system? What is Risperidol for the immune system? What is Valium for your immune system? Steroids would be like what? Like Valium. Steroids would be like heroin or Valium for your immune system. Steroids would suppress that T killer cell, but steroids would be a non-specific suppressant. It would suppress the eosinophils, the B cells, the neutrophils, the monocytes. The same way, if you have a psychotic patient, you can give them Valium, and it's like this. I'll kill you. I'll kill you. I'll kill you. I'm just too sleepy. I'm going to kill you as soon as I take a nap. So that's like Valium for the immune system. You can give steroids, but it just suppresses all functions. It's not relieving the disorder. What immune drug do you know of that just suppresses T cells? Kidney transplants? Organ transplants? Cyclosporin. Cyclosporin. So in this case, you think of it as more as psychosporin. Cyclosporin is like Haldol for the immune system because it affects just the T cells. It affects just the T cells. What's your first name again? Huh? Kassan. What would happen if we took some of Kassan's T cells and injected them into a horse's ass? Don't say nothing. That's not true. What would happen? The horse would die? Who would reject who? The horse would reject his T cells. The horse would reject his T cells. If we inject some of your T cells into a horse, the response would be antibodies to your T cells. The horse would go, oh, that's not me. Oh, put those T cells into me. The horse would have a little anaphylactic reaction to you, having a serum sickness-like reaction to this human serum being put into him. The horse would make antibodies against your T cells. So if we inject your T cells into a horse, your horse would make antibodies against the T cell, thymocyte, immunoglobulins, globulin, ATG, anti-thymocyte immunoglobulins, anti-thymocyte globulin. So what is Risperidol for that T cell is anti-thymocyte globulin. It's not going to affect the neutrophils. It's not going to affect the eosinophils. It's not going to affect the B cells. It's going to just selectively pull out T cells and kill off those T cells and not affect the rest of the immune system. And that's the management for aplastic anemia. You can give steroids, but it suppresses every portion of the immune system. Cyclosporin and anti-thymocyte globulin. And as nice as that might be, it only is used if you have no donor. If you have a suitable donor, you go straight to bone marrow transplantation. If you don't have a donor, that's when you use these things. Aplastic anemia, pancytopenia of unclear etiology. I have pancytopenia and I have an empty marrow that's replaced with just fibrosis. I have an empty marrow replaced with fibrosis and If I can donate and transplant that marrow, I transplant. If I can't transplant, I use cyclosporin and antithymocyte globulin to suppress the T cells. When I suppress the T cells, the bone marrow comes back to life. Questions on this? Okay. Yeah. Loudly and quickly. What?
Sometimes it may respond by itself.
Sometimes it may respond by itself.
So when do you wait and when do you give?
When it doesn't respond by itself, then you give these drugs or you transplant.
How long?
Not long in this case because the person's already very severely ill. All right, let's take 5. Next case. A 75-year-old guy comes to the office with the son, and Dad says, Dad is sleepy and stupid, wobbly and moody. Dad is erotic and volatile. What? What are you laughing at? Oh, you too? So the guy is erotic and volatile and drinks quite a lot. I don't even know what that means. I'm not even sure. How do you define an alcoholic? Someone who drinks more than their doctor, I suppose. You know? And you've got this guy who's an alcoholic 72-year-old guy, an alcoholic 72-year-old guy, and he appears confused and confused, but he knows who he is. And now he's got a decreased sensation, and he's lost the position of his vibrator. B12? I don't think that'll make the final cut. So, here we go. If a B12 is folate, what test would you get first? Well, I'll tell you that he's going to have an anemia. He's got a low hematocrit, and he's got a higher MCV. He's got a low hematocrit, and he's got a high MCV. And what test would you get next? The guy has a low hematocrit and a high MCV. In this patient, what test would you get next to determine the etiology? Almost the B12 level. Schilling's test is the wrong answer I'm looking for. Schilling's test does not diagnose a B12 deficiency. Schilling's test is after you diagnose it at B12 deficiency. Schilling's test tells you what the B12 deficiency was from. So Schilling's test is not to diagnose a B12 deficiency. Schilling's test is after you know it is B12 deficiency to say, what's it from? What's that from? What's that B12 deficiency from? What's it from? So what's it from? It's to tell you what it's from, that B12 deficiency, after you know it. The first test to get to determine the etiology is not a level, not a Schilling's. Methylmalonic acid as an initial test. Getting a methylmalonic acid level. Methylmalonic acid will be up in B12 and it will be down in everything else. Methylmalonic acid being up is very specific for B12. Methylmalonic acid is a very highly intelligent way of being wrong and very highly knowledgeable. But not a methylmalonic acid level, not a Schilling's test next, not a B12 level next, not a folate level next. What? I can't hear you.
Blood smear.
A blood smear? A little pissy little smear? That's a poltergeist. Do you get this thing, something ghosts walking by? I felt the presence. It's a cold spot here. What the hell are you going to see on a blood smear? It's going to tell you anything.
Multilobulated CNS.
Oh, not multilobulated, hypersegmented? Did you say that? Who said the hypersegmented? Was that you? So you're disagreeing with him when you know that he's right, in public, keeping physically distant in a relationship that does not include sex but public disagreements. Are you two married? Smear is the answer. Because if this smear is normal, then what's causing the anemia? If the smear is normal, what causes the anemia? If that smear is normal? The alcoholism. Oh. Alcohol can give you a macrocytic anemia. What's the most common drug that causes macrocytic anemia? Alcohol. Alcohol can cause dementia. Alcohol can cause lethargy. Alcohol can cause all these problems. Alcohol can make you lose the position of your vibrator as well. Where was that thing? I had it just here. If the smear is normal, it's from alcohol. If the smear is normal, it's from alcohol. If the smear shows hypersegmented polys or neutrophils, that's how you know that it's got to be either B12 or folate. What is the difference between macrocytic and megaloblastic? Macrocytic and megaloblastic. What's the difference between macrocytic is just large MCV. Macrocytic is just large cells. Megaloblastic is different. Megaloblastic means hypersegmented. Macrocytic, large cells. Hypersegmented polys is megaloblastic. So the difference is drugs can cause macrocytosis. B12 and folate can cause macrocytosis, a large MCV. Thyroid disease, liver disease can cause macrocytosis. Lots of things can cause macrocytosis, but only two things cause megaloblastic, and that's B12 and folate. So the first thing to do to see what the etiology is a smear. Now, people who said, oh, get an increased methylmalonic acid, that's true. Oh, people who said get a Schilling's test, maybe that's true. People who said get a level of B12 and a level of folate, yes, that's true. But these things should be done after you've confirmed that it's hypersegmented. These things should be done afterwards. B12 and folate. Hypersegmented, megaloblastic, in addition to being macrocytic. First you do the smear. And you remember that everything that B12 can do, alcohol can do, with the exception of one thing. Everything B12 can do, alcohol can do, with the exception of one thing. Huh? No. Alcohol can screw up your cord too. No. Megaloblastic. The only thing that alcohol can do everything else. Alcohol is a neurotoxin too. Alcoholic encephalopathy, peripheral neuropathy. Alcohol is a neurotoxin too. It's just that alcohol doesn't cause the hypersegmented polys. What is the difference between B12 and folate deficiency hematologically? Hematologically, what's the difference between these two things in terms of the hematologic picture? Nothing. In terms of their hematologic picture, there's no difference between these two things in terms of their hematologic picture. They're hematologically identical. Now, The obvious difference is that folate deficiency gives no neuro, and B12 deficiency does give neuro abnormalities. Now, what's the most common neurologic abnormality with B12 deficiency? What's the most common thing? Huh? What? Peripheral neuropathy, Lillian, or the cord, posterior column? Posterior column is or peripheral neuropathy. And the most common wrong answer is the posterior column. The most common right answer is the peripheral neuropathy. Peripheral neuropathy is the most common neurologic manifestation. Posterior column is the most common wrong answer. What other neurologic abnormalities can you get with B12 deficiency? Oh, subacute combined degeneration of the cord. Definitely. That's the posterior column finding. Mammary? Mammillary bodies. Those two little perky bits under the fornix. Mammillary bodies under the fornix? I think we need to take a break. No. Okay. So the thing is, well, degenerating your mammillary bodies, the little Cooper's ligaments and those things? No? All right. You can. What other neurologic problems can you have? Definitely dementia. More dementia. Position sense. Vibratory. Motor. Sensory. Autonomic. Bowel and bladder. Sexual dysfunction. Ataxia? Yeah. What neurologic problems can you have at B12 deficiency? Anything or everything? Both. You have two choices. You can do it the old-fashioned way. Ready? Write this down. Posterior column findings. Peripheral neuropathy, autonomic, motor, sensory, position, vibratory, dementia, psychiatric, bowel, bladder, autonomic, sexual dysfunction, or just say anything. Isn't it easier just to say anything? It is. It is. It's so much easier to say anything. Anything can happen, but what's the most common? Peripheral. Peripheral. Anything can happen, but peripheral is the most common. Anything can happen, but peripheral is the most common. And you know what's great about folate deficiency? It's macrocytic hypersegmented polys, low level of folate, and give folate. Somebody asked in the sickle cell case, when the folic acid level is low in sickle cell, what you give. But in that case, you give folate. In that case, you give folate. Oh, PO folate. How else would you give? Intravenous folate? No, folate. Here, you'd give folate. Yes, that's it. You'd give B12. You'd give B12, and now here's a little thing here. Okay, you ready? Here we go. We have a 72-year-old guy. A 72-year-old guy who comes in with fatigue, but his neurological exam is normal, and he's got a macrocytic hypersegmented polys. What's the diagnosis? The diagnosis is either B12 or folate deficiency. Either one. Either one. If you have neurologic problems, it has to be B12. However, if you have no neurologic problems, you could still have B12. You could have the neurologic problems without the hematologic problems. You can have the hematologic problems without the neurologic problems. Or you can have both together. You don't have to have one, then the other. You could have both or one individually. Either the hematologic or the neurologic ones. Either one. Schilling's test is hardly ever used. Schilling's test is, you know that it's B12 deficiency. Now, what's it from? Is it pernicious anemia? Let's give some intrinsic factor and see if it comes out in the urine. Oh, that didn't make it get better? Let's give some antibiotics and see if it comes out in the urine. Was it bacterial overgrowth? Oh, that didn't work. Let's give some pancreatic enzymes and see if it comes out in the urine. Was it pancreatic insufficiency? Oh, gee, which one is it? Let's kill that same little tapeworm that the entire world is chasing around, like the hunt for Red October. Okay? Chasing around. They have to diphyllobothrium laudum. Give the antihelminthic. Check it again. Does it come out into the urine? Schilling's test does not diagnose B12 deficiency. Schilling's test is you have B12 deficiency because I have a macrocytic anemia with hypersegmented polys, high methylmalonic acid level, and a low B12 level. Now, what's it from? Pernicious anemia? Diphyllobothrium laudum? Questions on B12 deficiency? Next, yeah. The cell folate or the RBC? Well, the RBC is the cell folate because the C in the cell, the C stands for cell. So what? He said, I can barely hear you, my dear. Red cell folate. You can ask whatever you want, but just also because the thing is going on here, just belt it out so we can hear you. Okay? Next case. A 28-year-old woman is brought here because it's easier for her gynecologist to send the patient to see you rather than look up microcytic anemia himself. See? So, what we have here is microcytic anemia. We know that microcytic anemia can only be a couple of things. We know that microcytic anemia has to be either iron deficiency, chronic disease, sideroblastic, or thalassemia. Now, chronic disease could be either microcytic or normocytic. Now, how will presentation help tell them apart? It doesn't. How does the smear help tell these apart? How does the smear help tell these apart? Well, which of these is morphology? Which of these is microcytic and hypochromic? All of them. They're all microcytic and hypochromic. So the problem is that smear actually doesn't tell you the difference very much. Smear doesn't tell you, Well, target cells are about a half a dozen different things give target cells, including liver disease and thalassemia. The ones that probably have more target cells is thalassemia. But the thing is that smear doesn't really help tell the difference between these. The only way to tell the difference between these, what is the initial test to distinguish between these? Electrophoresis is not correct. Iron levels and iron studies. Since you can't really tell the difference by the clinical history, the way to tell the difference is between these is with iron studies. Iron studies. What is the most specific finding for iron deficiency anemia? Decreased serum ferritin. Decreased ferritin is the most specific thing for iron deficiency. It's the only one that gives a decreased serum ferritin. Now, you can have iron deficiency with a normal ferritin. You can have iron deficiency with a normal ferritin. But if you have a low ferritin, the only thing that gives a low ferritin is iron deficiency anemia. You see, iron deficiency anemia means that you don't have any iron and there's no storage. Whereas in chronic disease, you have lots and lots of stored up iron. You just can't make any cells with it. So the iron level is low. They're both low. But you have no storage of iron here. Here your body is filled up with iron, but you just can't make any cells from it. So the iron is all filled up in the body, but you can't make cells with it. Now, for those of you who are with obsessive compulsive disorder and you can't help yourself, the most characteristic thing about the iron studies for sideroblastic anemia is it's the only one that gives an increased serum iron. It's none of the others will. Okay. So, here, in this patient, what you have is a microcytic anemia. Now, I will tell you what helps you, is that you have a very, 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 very profoundly low MCV and not very much symptoms. And when you see a really, really low MCV and not much symptoms, that almost always means thalassemia. Thalassemia. The reason is, you see that those cells are really, really small, but the hemoglobin is barely below normal? Those cells are really, really small, but the hemoglobin is barely below normal is because the body just makes more cells. So the MCV is low, and the body compensates for that by just making more cells. Okay. Rectal exam is guaiac negative, telling you that this is not blood loss anemia. Iron deficiency is almost always from some form of increased loss of blood. Now, if they take this patient and say that you have microcytic anemia with normal iron studies, that is all you need to know that you've got thalassemia. All you need is microcytic anemia and normal iron studies. It doesn't tell you which type, but here you have a low ferritin and a low iron. Here you have a high iron. Thalassemia is the only one with a microcytic anemia and normal iron studies, and that's enough to know that you have thalassemia. But it doesn't tell you which type of thalassemia. Now, what is the most specific diagnostic test for iron deficiency? What's the most specific diagnostic test for iron deficiency anemia? Bone marrow. Bone marrow is the most specific test. Bone marrow for stainable iron. Bone marrow for stainable iron is the most specific diagnostic test. Now, I never said that you do it. I didn't say to do it, but it is the most specific diagnostic test. I didn't say I do it, but it is the most specific diagnostic test. Okay? So bone marrow for stainable iron. Okay? Now, here, what is the most specific diagnostic test for sideroblastic anemia? What is unique to sideroblastic, different from all the others? Huh? You're speaking in Braille, my friend. Iron rings. Iron rings. Wagner. Iron ring. Bone marrow. Bone marrow. You're chanting. What on the bone marrow? Bone marrow, bone marrow. Bone marrow. The rings. The rings. What rings? I'll tell you, you're circling the airport. It's not a Botswanan test. It's not a test from Finland. It's not a Chinese blue. It's not a German blue. It's not a French blue. A Russian blue. Creamy Italian. Thousand Island. Ranch. Prussian. Not Persian. Who said that? Oh, a Persian blue. A Persian. You're biased. A Prussian blue. We want a blue test too. All right. So a Prussian blue test is the test that you're getting to look for those ring sideroblasts. It's true what you say. I want rings. I want rings. I want rings on things. But the ring sideroblast that you're thinking of is on the Prussian blue stain that looks for iron stored up in those mitochondria that are stuffed up in those cells. And the Prussian blue stain is actually the test you get anytime you're looking for stored up iron. I never said you'd have to do a bone marrow for iron deficiency, but it is the most specific test. It is more specific than the high iron binding capacity. It is more specific. Here, you have a low iron binding capacity. Capacity is the amount of empty spots. If this room is empty, there's a high capacity. If the room is filled, there's a low capacity. Here, the body is filled up with stored iron. Since it's filled up with stored iron, the capacity is very, very low. Since here the body is empty of stored iron, the capacity is very, very high. Since the body is empty of stored iron. But it's not as specific as a marrow. I never said I'd do it, but it is the most specific. It is the most specific. Okay. Now, treatment. When I was in medical school, we used to give iron for iron deficiency anemia. Now what do you give? You give iron? Yes, you give iron. What is the fastest way? What is the least efficient? Pardon me. What's the least efficient, the worst way to give iron? What's the least efficient, worst way to give iron? Huh? Oral what? Oral what? Oral sex, oral what? What? Oral? No. Ferrous sulfate. Ferrous sulfate. If you eat a raw steak, that's much, much more efficient. That's heme iron. If you drink blood, that's oral iron. It's heme iron. Oral ferrous sulfate, elemental iron, is the least efficient way. 99% of it ends up in the poo-poo. That's why your poo-poo turns black. Your poo-poo turns black because it's not being absorbed. What is the most efficient, most rapid way to give iron? What's the most rapid way to administer iron? How would I get some iron into you the fastest? What? Blood transfusion is correct. Blood transfusion is the fastest way to give iron. That is the fastest way to give iron. Blood transfusion is the fastest thing. Blood transfusion. Blood transfusion is the fastest way. Did I say I do that? I didn't say I do it. How much iron do you need a day when you're not menstruating? When you're not menstruating, how much iron? About 1 milligram a day. About 1 or 2 milligrams a day. All you need is about 1 or 2 milligrams a day. All you need, maximum amount that you need, all you need is 1 to 2 milligrams a day. And a non-menstruating person generally needs only about 1 milligram a day. A unit of packed red blood cells, contains 1 milligram per milliliter. 1 milligram per milliliter. That means 1 unit of packed red blood cells at about 350 milliliters has a year's worth of iron in 1 unit of packed cells. You can give a whole year's worth in 1 unit of packed cells. It's no wonder that kids with thalassemia major, and I'm not going into thalassemia major much because that's a pediatric disease, and it's not really an issue for us, but that is the reason why with thalassemia major, of course these kids get iron overloaded, because with 1 unit of packed cells every 2 to 4 weeks, they're getting a year's worth of iron every 2 to 4 weeks. So no wonder they get iron built up in their pancreas and skin, bronze diabetes. No wonder they get joint pains, liver disease. No wonder they get cardiomyopathy and testicles of steel. Because all this iron builds up. By the way, what is the most common cause of death with people with iron overload here? Liver or cardiac? Cardiac is the most common wrong answer. Liver is the most common. You die of the cirrhosis. The liver. Hemochromatosis in the liver. But that's why, because each unit of packed cells contains 1 milligram per milliliter of blood of iron. If you're not menstruating and you're not pregnant, you only need 1 milligram a day. Get a year's worth in each unit. No wonder they get it. Heart, liver, pancreas, bone. Heart, liver, pancreas, and bone. The least efficient way is oral ferrous sulfate. The most efficient way is give a blood transfusion. Treatment for anemia of chronic disease is? Fix the disease. Doc, it hurts when I do this. Don't do that. Doc, it hurts when I have rheumatoid arthritis. Don't do that. Don't have rheumatoid arthritis. Oh, I'm glad you told me that. I'm glad you told me that. Thank you very much. Thank you very much. Sideroblastic anemia. What is the most common cause of sideroblastic anemia? Alcohol or lead? Lead or chloramphenicol? Huh? The most common cause is? B6. Lead is the most common wrong answer. Can you go down to the supermarket every day? Hey, honey, can you go to the store and pick me up a case of lead? I'd like to have some single malt lead on the rocks. Moonshine? Why does anybody need moonshine when you could have Samuel Adams? Alcohol. The whole society's level of lead dropped enormously in the last 25 years. So much so that the cutoffs for the abnormal were dropped because the whole level dropped in the whole country when the gasoline was de-leaded 30 years ago. When the gasoline was de-leaded in the 70s, the amount of lead in the whole country went dropped down. So lead poisoning is about 90% of it is gone. So alcohol as sideroblastic. Yes, it's true. Chloramphenicol, isoniazid. Yes, it's true. But they're not as common as alcohol. Not as common as alcohol. Okay. Now, thalassemia, all you need is that it's target cells, it's microcytic anemia with normal iron studies, and that's enough for you to know that it's thalassemia, is that you have a microcytic anemia with normal iron studies. That's enough. But it doesn't tell you whether you have alpha thalassemia or beta thalassemia. What do you get to tell you whether it's the alpha or beta? Is the electrophoresis. So the electrophoresis is what tells you whether or not you have the alpha or the beta. Now, normal hemoglobin A is 2 alpha chains plus 2. Hemoglobin A2 is 2 alpha chains plus 2. Hemoglobin F is 2 alpha chains plus 2. Hemoglobin A is 2 alpha chains plus 2 beta chains. Hemoglobin A2 is 2 alpha chains plus 2 delta. And since I don't know how to do a delta in Greek, I just write out a 2 delta. And then somebody always goes like this. Hemoglobin F is 2 alpha chains and 2 gamma. But I don't know how to do a gamma in Greek, so I just write out a gamma. And then somebody goes, oh, it's... yeah. Microcytic anemia, normal iron studies, it's thalassemia. Microcytic anemia with a very profound microcytosis, but not much symptoms, thalassemia. Very small cells, but not much symptoms, thalassemia. The most accurate diagnostic test, hemoglobin electrophoresis. In beta thalassemia, I'm not making enough beta chains. I got all these nice alpha chains. But I don't have these beta chains. So I got all these alpha chains, but I don't have a beta chain. So if you're in the business of making blood, you got to get out a certain amount of blood. You're the foreman of the factory known as the bone marrow. If you're in control of the manager, controlling bone marrow output, and you got to get out a certain amount of hemoglobin, and you know that in your factory you don't have enough beta chains to make hemoglobin, all you do is you say, well, I got all these alpha chains, so I'll match them up with delta and gamma chains. So I take all these alpha chains I have, and I just match them up with the other chains. So I get an increased fetal and an increased A2. I got all these alpha chains, but I don't have my beta chains. Since I don't have the beta chains, but I do have alpha chains, I'll match them up with delta and gamma and increase my A2 and my fetal. And I know that I have beta thalassemia, and I'm done. Now, beta thalassemia trait is what we're mostly concerned with in adults. The beta thalassemia major is all a kid's disease. Okay, and it's very, very, very rare. Trait. Alpha and beta thalassemia trait is easy. How do you treat a trait? Nothing. Or genetic counseling. What does that mean? Genetic counseling. Do genetic counseling on me. Show to me what it's like. No, it's not don't have kids. How do you do it? Come on, genetic counseling. Don't what? Don't date. Well, it's not the dating that's the problem. It's the pollinating. You can date, but you must not pollinate. I should remember that. Date, but don't pollinate. That is genetic counseling. Remember, genetic counseling is like this. Oh, hi, yeah. Oh, I think you're cute. Oh, I think you're cute, too. You want my number? No. 2 red top tubes of blood. For the hemoglobin electrophoresis. What's the other one for? I'll tell you later. Now, so trait, there's no treatment for trait. Either alpha thalassemia trait or beta thalassemia trait. There's no treatment for a trait. Now, what's the treatment for thalassemia major, for the hemochromatosis of the thalassemia major? What's the treatment for the hemochromatosis of the thalassemia major? What'd you say? What? Phlebotomy. Phlebotomy? 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 Phlebotomy. Okay, so this is how we treat the thalassemia major. You come in on Monday with thalassemia major and you get a transfusion. On Friday you come in and you get phlebotomy. Then you say, Doc, can we make this a little more efficient? He says, well, why don't you come in on Tuesday for the transfusion? So you come in on Tuesday and you get transfused. And you come in on Wednesday and you get the phlebotomy. He said, Doc, can we do this on the same day? Okay. So you get transfused in this arm and you get phlebotomy from that arm at the same time. And you go, listen, I got one step better. What can we do, Doc? We could take the blood and throw it straight in the garbage. The most common wrong answer is phlebotomy. Now, the problem is, clearly, you got all this iron in you, you got all this ferrous material in you, it's building up in your liver, your skin, your pancreas, and you have testicles of steel. You got all this iron in you. Oh my God, I got all this iron in me. I got all this iron in me. What am I going to do? I can't phlebotomy. I can't phlebotomy you. You can't phlebotomy me. But I got all this iron in me. Well, what am I going to do to get rid of all this iron, all this ferrous in me? Oh, you're going to deferoxamy. Deferoxamy. Deferoxy you? No, I'm not going to deferoxy you. I'm going to deferoxamy. Yeah, get all this iron off of me. Deferoxamy. Don't answer phlebotomy for people that you're transfusing every 2 weeks. Bad boy. Bad. Trait is easy. Don't treat a trait. Don't treat a trait. Just don't pollinate with people who have the same genetic defects you do. Okay? Now, this is where alpha thalassemia makes everybody crazy. The reason alpha thalassemia and these thalassemias make people crazy is that people could sort of relate to the fact that there's thalassemia major and thalassemia minor. You're like, okay, all right, major, minor. Major is bad, minor is good, better. All right, I can live with that. Thalassemia, microcytic anemia, normal iron studies. Punto solamente nada más. That's it. The hard part is you get this alpha thalassemia, and then they go like this. I have just finished a hematology fellowship. I spent 3 years learning what you could have learned with Fisher in 5 hours. I've got to make it as complex as possible. Now pay attention to me. Like Obi-Wan Kenobi. You must learn thalassemia. You must learn thalassemia. 1 gene deleted, 2 gene deleted, 3 gene deleted, 4 gene deleted. And most people at this point typically go like this. I'd rather fail than have to learn this. Because there are 4 genes controlling the alpha globin gene. There are 4 genes controlling the alpha globin gene. Listen, don't worry about 1 gene deleted. You never hear about them. They have no symptoms. 1 gene deleted you never see. 1 gene deleted never complain of anything. 1 gene deleted never show up for appointments. 1 gene deleted never go to the emergency room. 1 gene deleted never cause you a problem because 1 gene deleted is the... 1 gene deleted is the... It's not trait. It's not trait. 1 gene deleted is the... It's what? It's what? The silent carrier. Chirp, chirp, chirp. It's a silent carrier. You never see them. And you know what? 4 gene deleted, you never see them either. They never show up. They don't cause a problem. They don't keep their appointments. They never go to the emergency room either. They never call you in the middle of the night because they're dead. They're dead. That's hydrops vitalis. 1 gene deleted is completely asymptomatic, had nothing going on. 2 gene deleted is the trait. And what you basically run with here is you have a little mild anemia and a little moderate anemia, and that's it. So we take all this and we say, mild, moderate, 4 genes to do it. No treatment for a trait. Don't treat a trait, don't treat a trait, don't treat a trait. Genetic counseling. Only reproduce with people who have different genetic defects than you do. Don't build up too much recessives, honey. Okay? That's why arranged marriages last longer than marriages for love. Okay? Worry about that later. Questions on this? You didn't see my ad? You didn't see my ad? Your mother already arranged for me for you. Thalassemia? Okay. So we're over here. Target cells and basophilic stippling. Forget about basophilic stippling. Spend your whole entire medical career trying to figure out what to do with basophilic stippling. And then it becomes microcytic anemia with normal iron studies. Forget about basophilic stippling. Target cells are suggestive, but it's not the only thing. The reason the red cell count is elevated is that the number of cells is elevated because they're smaller. So the body is compensating by making more cells that are smaller. The iron and the ferritin level are normal, and even though you could have iron deficiency anemia with a normal ferritin, you can't have a normal iron and a normal ferritin. So therefore, we have iron deficiency, we have microcytic anemia with normal iron studies. Our hemoglobin F and A2 is up, and automatically we know that this is thalassemia. Now, just from what we see here, is this thalassemia major or thalassemia minor? Could it be thalassemia major? No, it's impossible. It's impossible. You don't get to be 26. How old is she? 26 years old? 28. You don't get to be 28 years old going like this. My diagnosis? I don't know. Oh, that catheter in my chest? Oh, is that why I need those transfusions every 2 weeks? I've always been wondering about that. So people don't get to be 28 years old with no diagnosis. So it has to be minor because the woman's asymptomatic. Questions on thalassemia? Next case. Period lasts for 7 to 8 days. Woo-hoo! Long, long, long. Vegetarian. She's got symptoms. You see the difference between this and the previous lady? This lady has a lot of symptoms. She's fatigued. She's tired. The other lady wasn't. The other lady had a very profound microcytosis with not much in the way of symptoms. This person has much more in the way of symptoms. She's pale. She's fatigued. She's weak. She's got a microcytic anemia with hypochromic microcytic. Now, which one of those is hypochromic and microcytic? All of them. All of these can be hypochromic and microcytic. It doesn't help. It doesn't help. It doesn't help. They all can be hypochromic and microcytic. Which of these can give you a low retic count? They all could. There's one thalassemia that gives a high retic count, but it's not worthwhile going into. They all are production problems. They all can give you a low retic count, so that does not help. Microcytic anemia does not help. The smear does not help. What helps is that we see that it is a low ferritin and a low serum iron, and we know that it has to be iron deficiency anemia. Next case, thank you very much. Questions on that? Now, this is sort of a silly case to a very important issue. I come because I want to be checked out for cancer. I come because I want to make sure you get all the questions right for cancer screening. Now, there's not much of a case going on here. But the point is, she's a 52-year-old woman. What cancer screening test should she be getting? She should be getting what? She should get a mammogram? Yeah? What year should mammos start? 35? 40? The answer would have been different before, but now we'll say every year after 40. Every year after 40. The answer would have been different 6 months ago. 6 months ago, I would have been sitting here and saying 50. But the standard was just changed. The standard of care was just changed. So now we'll say every year after 40. Why? Well, because we got to pay for something. Then you get a PAP. Starting at what age? 13? Only in your family. 13? 18 or? Oh, that's why he said that. All right. He said 18 or first sexual activity. Okay. So the age 18. Now, how often? On average, about every 3 years. What else should she get? She should have a colonoscopy. Starting what age? Greater than 50, every 10 years or so. What about flexible SIG? When do you use a rigid SIG? Since we're talking about flexible, you say flexible. When do you use a rigid? Okay, I see people like, oh my God. Okay. Well, no, I need to get to know you better. So the answer is you do never use a rigid SIG. How about a digital exam? Can we have a better answer to questions than digital exam? How about it? It's like those clubs down in Bensonhurst in Brooklyn. Hey, baby, how about it? It's like, I'm sorry, I don't date outside my own species. Digital rectal. When do I start? Stool for heme. You know why I say heme and not guaiac? Because I don't know how to spell it. I've been trying to figure out how to spell guaiac for 15 years. Stool for heme starts at the age of 50 every year. Does she need the finger or just the guaiac? Everybody says finger, put your finger up. I feel like we should be like a concert. Should we hold up lighters? Can you feel that prostate in her? What are you doing the finger for? Why are you giving her the finger, my friend? Well, you know what it is? That may be so. That may be so. But the thing is that as many colon cancers are distal, they're not within the reach of a finger. So that may be so, as you say, but that you could sometimes find it. But the thing is that they're just screening digital rectal exam does not have sufficient sensitivity to be effective. So it is not a recommendation for everybody. What about a prostate? Oh, here we go again. Prostate. How about it? How about a prostate? No, thank you. I have one. Huh? For prostate. You want to do the finger? Doesn't help. No. No, I know. Listen, I know you want to. I know. Okay? I know, I understand. I know, but you're projecting. You're projecting your own perversity on the me. But the answer is digital rectal exam is not a routine recommendation. It's never been shown to lower mortality. The American Urologic Society says it, but not the United States Preventative Public Health Service Task Force. PSA? PCA? No. Okay, he's finita. Okay. No, I'm telling you, she does not need the finger, and neither does the man. Okay? Anything else is routine screening? What? Pelvic exam. No. Pelvic exam, fingers are not sensitive enough to feel those ovaries, not enough. What? Screening, what about breasts? Can you have a better question than what about breasts? Hey, breasts, what about it? Why bother taking this exam? Just surrender your license now. What's the mammogram? Is this not breast enough for you? Oh, I thought you meant prostate. You're talking about breast self-exam? I'm sorry. All right, at what age should you start touching yourself? Breast self-exam. Breast self-exam. I touch myself. 20. Starting 20. How often should you touch yourself? Monthly. Again, a married man. All right. Breast self-exam is every month. Breast self-exam is every month starting at age 20. Is there screening tests for ovarian cancer? Ultrasound's not a routine recommendation. CA-125 is not, there is no tumor marker. If you see any tumor markers, they're always wrong. Now look, don't mistake me goofing around for the seriousness of the data. The point is, after 8 hours in a day, how do you expect them to remain awake? But the issue is that these things here are much more important than you think about, because if you're designing a Step 3 exam, this is what you want people to know as they're taking their last licensure exam. This is the type of basic thing. Ovarian cancer, there's no screen. CA-125 and ultrasounds are not routine screen. The one that gets people the most crazy is the thing about rectals. Because then you're sitting there going, well, how come my attending kills me every time I don't do a rectal then? I don't make the news, I just report it. It's not the Conrad Fisher MLE. Is there screening tests for lung cancer? No. What about yearly chest x-rays? Who gets yearly x-rays? Nobody. There's only one lesion you can find on an x-ray to tell you somebody that got a smoking risk. You find a pack of cigarettes rolled up in their sleeve up here. And that's about it, okay? Is there an equivalent of a pap smear or mammogram for a man? Is there a testicular mammogram? No? Not a yearly test? Take the scrotum, pull it out, sandwich it in between two cold plates of metal and shoot radiation through it? Is there a penile pap? Get a little really small speculum? No, that's it. That's it. Digital rectal, I'm sorry. I'm sorry, that's not it. What? Skin exam. Most people should have skin exams, yes. For melanoma. Okay? Now, these things, ultimately it comes down to, we don't have to agree or disagree with them. We just have to know them. As much of a small data set as it looks like, this is good for 3 or 4 points right there. Okay? I will see you in the next tape.